And thank you for joining us for today's webinar titled inHEART on the Podium. We're joined by Dr. Jeffrey Winterfield, who's the Hank and Laurel Greer Endowed Chair and Professor of Cardiac Electrophysiology at the Medical University of South Carolina, by Dr. Timothy Maher, Electrophysiologist at Beth Israel Deaconess Medical Center in Boston, and by Dr. Nikola Pavlović, Head of Arrhythmia Department at the University Hospital Dubrava in Croatia. Our guests will be sharing case reports and clinical data on the inHEART platform that they recently presented at various scientific conferences around the world. In addition, we're joined by guest panelists, Dr. Andre Davila, Director of Cardiac Arrhythmia Service and the Harvard Thorndike EP Institute in Boston, Dr. Arian Sultan, the Associate Professor and Co-Head of the Department of Electrophysiology at the University Hospital in Cologne, and Dr. Christian Sticherling, Professor and Head of Electrophysiology at University Hospital in Basel. We're also joined by inHEART co-founder, Professor Hubert Cochet from the IHU Lyric in Bordeaux. My name is Katie Arnold, and I will be moderating today's conversation along with my colleague, Jody Lombardi. We will be recording today's discussion for use online and to share with clinicians. So your continued attendance will serve as consent to the audio and video recording and its distribution. Our format for today includes 3 case study presentations, followed by a Q&A. Attendees are encouraged to submit questions throughout the presentations via the Q&A feature, which is at the bottom of your screen, and we will then work to integrate your questions into the conversation. So we have great cases to cover, so let's get started. Dr. Winterfield, we'd love to start with your presentation.
Sure. Thank you for the invitation to join you. Let me go into presenter mode here. And switch. There we go. Okay. Well, we just wrapped up the VT symposium last weekend in Philadelphia, which was the 18th of those conferences, alternating between New York and Philly, and was a real honor to be able to present some of our work there that recently was published in JACC EP in collaboration with the Bordeaux group. And much of our interest in VT is, at least at the 30,000-foot level, is to make it more accessible, make it safer for patients. And at least as of the 2009 guidelines for VT ablation, there were no recommendations specifically around how to preoperatively assess risk for VT ablation until about 7-8 years ago, when Pasquale Santangeli and the group at Penn looked at 193 consecutive patients and looked for predictors of acute hemodynamic decompensation, and found that about 11% of patients had acute hemodynamic decompensation with a significant impact on overall mortality. Now, what was most interesting about that was, at least to me, that most of those deaths occurred during VT ablations where the cycle lengths of the VTs were actually slower than they were in patients in which hemodynamic decompensation did not occur. So that speaks to the possibility that substrate ablation alone may be problematic and does not exonerate you from risk of hemodynamic decompensation. And so from those 193 patients, Santangeli and colleagues at Penn identified or developed what was called the PAINS 2D, or the PAINS D score, which is based on multiple clinical parameters, including pulmonary disease, age, the use of general anesthesia, ischemic cardiomyopathy, and that's going to be interesting for us in a minute as we talk about how to apply this perhaps to non-ischemic populations, advanced heart failure, low ejection fraction, VT storm, and diabetes. And a logistic regression analysis, those were multiple predictors, and to develop the score, the risk was rounded to the next integer to assign a score. And about 2/3 of those patients in that high-risk group underwent substrate-guided ablation alone. So hemodynamic collapse did not occur in VT. And so they went on then from that small cohort of 193 patients, they went on to confirm this in a larger registry of the International VT Center Consortium of about 2,000 patients treated in about 12 centers. And what they found was a significant reduction in overall risk as Payne's D-score declined. Okay, so why do we care? Well, if somebody decompensates during an ablation, why don't we just crash onto mechanical circulatory support with ECMO or an Impella? Well, it turns out that when that happens, mortality is still quite high. And this is a retrospective series of 21 patients with VT Storm who decompensated in one center at Penn. ECMO was commenced in all 21 patients, and 16 of 21 patients died on average or within a median of about 10 days. The other 7 that survived went beyond about 6 months, and 3 went on to VAD and transplant. So crashing onto hemodynamic support does not always improve outcomes. In fact, it is associated with worse outcomes. So can we identify risk ahead of time? And so here's a patient that we took care of that was sent to us with a high Payne's D score, had a large remote anterior wall MI, ultra low ejection fraction, advanced heart failure, on amiodarone, was a smoker and had lung disease, and ultimately had a Payne's D score of 23. Okay, underwent the ablation that you see on the left. See that large anterior scar with our lesion sets, essentially decored the whole scar, rendered it non-paceable, was non-inducible, and he went home the next day with no complications. Okay. What about in an intermediate risk case now? This is a mixed cardiomyopathy case, patient who had diabetes, mixed cardiomyopathy with an EF of 42%, atrial fibrillation, and a complex valve history. It had an AFib ablation over a decade before, had a Mays operation with a mitral valve repair and left atrial appendage clipping in 2009, and then 10 years later required a reduced sternotomy with a mechanical mitral valve replacement after a failed clip. Had a BIV ICD in place, had been on amiodarone for a while, and also had coronary disease. But when we added everything up, the Payne's D score was only 12, and so came to us as a transfer with recurrent slow VT, and at the time of the index ablation on the 10th of June in 2021, had these 3 VTs, all relatively slow, all within the acute hemodynamic risk group that was noted in that index paper by Santangeli. So substrate modification was attempted, but the patient required escalating pressors and had rising lactate, which necessitated premature termination of the procedure and transfer to the intensive care unit for heart failure management and ongoing use of pressors. So are there other opportunities for imaging? Can we improve upon our prior failures and predict outcomes with advanced imaging? And so this is a slide that, that was provided to me by the Bordeaux group. Hubert Cochet sent this to me a couple of years ago. And it basically makes case, at least in the post-MI series of ischemic patients, that there's a very nice correlation between the multiple parameters of imaging identified on both the arterial and late iodine phases that correlates with anatomy. And not only that, and most importantly, if we look to the right, late iodine enhancement, which is a surrogate for late gadolinium in MR context, looks superimposable. So we can discern some important scar information with late iodine. And in our center at MUSC was a leading center for developing dual energy source imaging for late iodine. And so we pursued that. And so the question then is, can scar imaging in non-ischemic cases yield similar results to what was observed by Hubert and his colleagues in ischemic cases? And this is a paper that's currently under review between us and the Brigham group, assessing late gadolinium enhancement and late iodine. Equivalency for scar and panel A, you have the arterial phase where there's no detectable myocardial anomaly, and panel B, you have the delayed phase at 8 minutes with septal and inferior mid-wall myocardial and hyperenhancement. And then if we look in panel C, it's the same patient now with an MRI showing a similar scar pattern. Okay, and so we also learned from a small prospective series done by Benjamin Burt and Hubert, among others, in Europe, looking at 49 patients, that imaging can certainly improve perhaps outcomes. Maybe it doesn't change event-free survival, but procedure times can be enhanced or improved upon with pre-procedural imaging. So we've got a series of over 200 patients now, although more recently we've undertaken detailed scar imaging. And from this patient that I just presented with intermediate risk that decompensated in the laboratory, we then went on to get a cardiac CT and found scar defined as 110 to 130 Hounsfield units and measured a volume of 73 mLs with inHEART. And dense scar was defined as anything greater than 130 Hounsfield units with a volume of 22.1 milliliters. And we then went on to place an impella, given the observations of the last procedure, and found 3 non-mappable VTs, all faster now, underwent substrate modification with acute success, and remained VT-free on low-dose amiodarone, and was only now recently, in the past month, listed for transplantation due to a decline in ejection fraction. And this is the heart itself. And what we see here is this problem of quite a lot of late iodine enhancement in blue that really occupies a substantially greater area than the wall thinning observed. So we went on to ask a question: can we predict hemodynamic decompensation risk with late iodine enhancement? And this is my fellow Leah John, who has just recently finished a research fellowship at the Brigham with Usha Tedrow and Will Sauer, and went on to look at 72 patients who underwent VT ablation with late enhancement CT over a 2-year period. We excluded anybody that did not have sufficient imaging quality or the presence of RV or congenital disease. And we found 61 patients, and of that 61, 13 experienced hemodynamic decompensation, a similar ratio to what had been observed in the index retrospective series by the Penn group. And in our single center retrospective mixed population, about half were ischemic and a little less than half were non-ischemic. Almost 2/3 were enriched with more advanced heart failure, and at 13 of those 61 required acute hemodynamic or developed acute hemodynamic decompensation, requiring mechanical support, multiple pressors, prolonged ICU stays, and premature termination of the procedure. And the basic premise is really simple. Can the scar quantification provide additional value for hemodynamic decompensation risk? If there's lower scar, there's lower scar burden, or lower risk with lower scar burden, and vice versa. If there's higher scar burden, there would be potentially higher risk. And so we went on to look with Pearson correlation. Total scar volumes were independently associated with acute hemodynamic decompensation, and in fact, the average volume was approximately 40 cc's versus 25 cc's for the decompensation group versus the control group. And in a tertile analysis of scar volume, the top tertile had a risk of 4.8, which we rounded up to 5. And so if we go back to our index patient now, with dense substrate, we observed with extensive wall thinning, late iodine, we found quite a bit of scar. And with the new PAINS, what we developed as a PAINS 2D score, it was then bumped up to the high-risk category of 17. Looking at the ROC of PAINS 2D versus PAINS D, there was a slightly improved AUC of 0.73 versus 0.67, which did not reach significance, and that was not the purpose of the study. It was really to show the feasibility of using scar to predict risk and perhaps enhance risk, okay? There's obviously, this is a novel idea, a novel concept. There's a lot of debate in the field about the role of late iodine versus late gadolinium, and certainly we need more data, and we are working on that. My colleague and friend at Johns Hopkins, John Crispin, wrote a very thoughtful editorial of our paper, and Jackie P. And indeed, there was no external validation cohort, which we are looking to do. There just aren't enough centers doing late iodine at the present time, but data we are working on. Another criticism of this proprietary imaging software, scar delineation is subject to expert imaging review. And I think that's a little unfair on some levels, but there is some human input to say, and Hubert may be able to comment on that. 11 of 72 patients were excluded from analysis due to streak artifacts, and that is a problem. And we are limited in some cases by the presence of streak artifact. We just can't do the analysis. And then, of course, a tertile analysis in a single cohort does limit the generalizability of that threshold and requires validation in a larger cohort. Okay. So some future directions, pre-procedural imaging in preparation remains critical for improving in outcomes in both acutely and avoiding complications in our sick VT population. Acute hemodynamic decompensation is clearly associated with poor outcomes, yet our predictive ability does remain limited. Imaging and clinical characteristics may improve our risk prediction models for acute hemodynamic decompensation. And upcoming, the IVTCC 2.0, which I'm leading the imaging core for, may provide external validation cohort in the future for this. And what we still require as a field is whether or not pre-procedural hemodynamic support based upon risk scores that are calculated either with clinical parameters and clinical plus imaging parameters, still requires further study and validation. Thank you very much. And I also want to thank my team and our fellows for their superb work and engagement to make all this possible.
Thank you, Dr. Winterfield.
Thank you.
I think for right now, I'd like to open the questions up to our panelists and other presenters. Anyone have any questions to Dr. Winterfield or Hubert? Do you have a comment on the streak artifact limitations?
Yeah, well, I can start. But I saw that Christian, so please to pass the mic to Christian afterwards because he will raise his hands.
Do you want to start?
Yeah, just to congratulate Jeff and Leah on this job. This was a great job. With respect to the questions that you raised, so I'm going to answer these, or that the reviewer raised. It's true that there's less data available in the literature to validate late iodine CT than late GAD-MR, but intrinsically CT is more reproducible than MR. So I'm not saying that it's highly reproducible. I'm saying that MR also has the same issue of reproducibility of scar quantification. When you're talking about milliliters of scar, it's highly dependent on the MR sequence you're using and stuff. And I'm not sure that CT is worse than MR, at least with recent CT systems, and the new generations of CT systems will probably make this even easier to quantify. I have two questions. The first is, wouldn't it be simpler and probably much more reproducible to just count the AHA segments to quantify this scar extent? You know, within inHEART, we provide the volume of the scar, but it's also easy to look at the model and, okay, that there's a large scar, there's a high risk. You know, did you try to understand what your threshold means in terms of number of AHA segments?
We did not look at AHA segments in this analysis. We actually have a manuscript. I was just before this call a couple of hours ago. I was actually on a research call with Leah. And she's meeting with Usha this afternoon, Usha Tedrow, this afternoon to discuss a separate manuscript that is assessing the late iodine and wall thinning in individual AHA segments and assessing outcomes. And that's data that you and your group provided. And, you know, we'll look forward. We actually will be forwarding that manuscript for your review very shortly, probably in the next week.
Yeah. But maybe if you want to implement that on the field, so people to use this scar size as a threshold to act and to trigger some different approach in patient management. I guess counting the number of segments roughly visually, it looks rudimentary, but it's possibly more reproducible than these thresholds that we put on histograms on MR and CT, which are very dependent on the noise, the artifacts and stuff.
That's a very good point. We have, I think that would be best done if we are able to obtain a larger pool of data.
Yeah, definitely, you need that. Yeah.
It just we only have 13 patients with acute hemodynamic decompensation, so it's very difficult to obtain at least enough statistical power to draw meaningful conclusions about whether there are differences in AHA segments that would influence outcomes. It's parsing the data a little too much, but This was the first question was largely, is there meaning in scar volumes? And that was felt to be, as we discussed many times, a potentially useful way of thinking about the role of scar in hemodynamic decompensation. Because if you look at some of the older literature, particularly when I finished training, and you go back to the original Thermocol trial from 2008, there was measurement of scar areas based upon the Cardo map, and that's just a two-dimensional surface in a sense. And you are getting scar information, but it does not in any way give you a sense of what the overall scar volume. And in fact,
particularly non-ischemics, yeah,
right, particularly non-ischemics.
And the last question that I would have is, okay, so this was research, so the link between scar and hemodynamic decompensation, but then this information clinically, how do you make use of that? What's your approach when you have a very high score?
Well, it's funny. We just I had a patient transferred in. It's been another typical VT week where we've had 3 transfers just in the past 48 hours or 72 hours. And I did a case just the other day that came in and had a very high, had a high pains D and a high pains 2D score. And we actually did place the Impella. And it was, again, we spend most of our time in sinus rhythm, but our cardiac anesthesia folks, and we have expert cardiac anesthesia in all of our cases, still struggle to support the patient. So the Impella did make a difference. But you are alluding to a data vacuum in terms of the utilization of mechanical circulatory support percutaneously to get us through these procedures, and we just don't have that. And there's not been a tremendous degree of interest from Abiomed to support a trial, right? So we certainly know there's more complications, and if you look at Pasquale's work out of the clinic, since he moved to the Cleveland Clinic, he just published a recent series showing that really there was no difference, at least in terms of outcomes. But this needs to be vetted a little bit more, I think, in this population, and imaging may be a useful tool.
Thanks.
Christian? Sticherling?
Yeah, thanks, Jeffrey, for sharing this really exciting data. I've got 2 practical questions. Number one is, how many of the images of the CT-late iodine can actually be used so that you see intramural non-endocardial scar? And the second question is, how does it impact on your ablation strategy? I mean, you do know that you have a larger scar volume, but do you change your strategy in any way as compared to purely looking at wall thinning?
Sure. So the first point, we roughly, and we can, it's about 10% of the scans we may have to exclude. And Hubert may know that because we look at our data periodically, but I would say it's about 10% where we have to exclude through nobody's fault. It's just that there's artifact, and particularly, let's say it's a lateral wall late iodine, and there's a LV lead in place that may become problematic, and that's something that again, we're sharing our data with the Brigham group, and we're taking a look at that specific issue. But it's a minority of cases. In most cases, we are able to obtain late iodine enhancement.
So more often than with MRI?
I'm sorry?
Is that more often than with late gadolinium MRI?
Well, so we obviously prefer late gadolinium MRI. The problem we have in our center, and I think in most centers, is that it becomes more challenging to get MR in the setting of a device. I know UCLA published the wideband protocol, and it's just not been very successful in our hands. It wasn't when I was at my previous job. I worked for David Wilbur at Loyola after I left the Brigham in 2011, and we still struggled, with MR in all those settings. I know, anecdotally from colleagues at other large centers that they have a similar experience. So CT is felt to be more accessible. And the other advantage from my perspective of CT is it's done very well here. It's just the local expertise of our institution, particularly with late iodine and dual energy. And we have the luxury now of really thinner cuts, sub-millimeter or millimeter level cuts. And so when we reconstruct a ventricle, we have, I think, richer detail, both in terms of wall thinning and in terms of late iodine. So it is our preference. And at least in most of our patients have implanted devices already, so MR becomes less accessible. The second part, it depends on the substrate, whether it influences the ablation decision. I think Tim is going to present some very nice data about the role of wall thinning and functional substrate, and that will be that's very exciting data. I can admit this now, Tim, I reviewed that paper and loved it. And, to be honest, he scooped us, which was, totally, it was really nice data and needed to get out. In non-ischemic settings, late iodine in the septum in particular may focus my interest, particularly if the VTs are coming from that region, even if I see normal endocardial voltage. Bipolar endocardial voltage will direct more aggressive RF to those locations.
Thank you, Dr. Winterfield. That was a great transition to Dr. Maher's presentation. We'll go ahead and move on. If there are additional questions for Dr. Winterfield, we can save them for the end after we get through all of our presentations. So Dr. Maher, we'll turn it over to you.
All right, let me fire up my screen here. Is that projecting for everyone?
It is. It looks good.
Okay, great. So thanks for the invitation. I'm happy to be here and discuss our experience with the inHEART platform and VT ablation. So the title of my presentation today is Structure and Function Correlating ILAM with CT Wall Thinning to help guide VT ablation. Here are my disclosures. So as Dr. Winterfield just mentioned, we have our paper relatively hot off the presses, looking at our experience with functional substrate mapping using the ILAM technique with CT-derived wall thinning using the inHEART platform. So functional substrate mapping through using ILAM or isochronal late activation mapping can be used as a strategy to target surrogates for VT isthmuses to help do substrate ablation. And that's really targeting D-cell zones as that surrogate. Alternatively, other work from the Bordeaux group has also showed that advanced scar imaging reconstructions can prospectively identify candidate areas for mapping and ablation to make VT ablation more efficient. And even these wall thinning channels, which I'll talk about in a second, actually correlate with lavas and VT isthmuses as well. So we have two separate strategies, functional and anatomic, that can be used to help assist with substrate ablation. What is unknown is whether CT wall thinning and wall thickness channels, whether they co-localize with each other. So can we learn more about this structure-function relationship? Many people are familiar with ILAM mapping. This is using sinus rhythm or paced rhythm to develop late activation maps where you annotate the last signal or last deflection. And you look for areas of isochronal crowding, which can focus your ability to look at the substrate. It's often in a smaller area than the bipolar scar, and targeting these areas can allow you to do the substrate ablation with only ablating 15 to 20% of the scar, rather than having to homogenize the whole scar in cases where VT is non-inducible or not hemodynamically tolerated for mapping. The gold standard for imaging, as Dr. Winterfield mentioned, is late gadolinium enhancement delineation of scar. You can get a lot of information from that, including using the inHEART platform to segment endocardial, mid-myocardial, or epicardial LGE to help guide your choice of axis and your type of mapping. The problem is that MRI and the ability to do MRI in patients with ICDs is not necessarily widely available in all centers, and has its own limitations with artifact and resolution as well. So alternatively, cardiac CT, which has very high spatial resolution, can be used for integration into the mapping as well. You get fine anatomic details that can help you perform this procedure safely, as I show here. But you'll also get information about the scar and the substrate as well, via wall thinning, as well as late iodine enhancement. In our center, our signal to noise ratio with an older scanner is not quite on par with expert centers like MUSC or Bordeaux. That's why we explored wall thinning as our surrogate here. So here's a color heat map of wall thinning over the CT reconstruction, showing the thinnest areas with dark red, the normal areas with no color, and then the color gradient from there from 5 millimeters down to 1 millimeter. So in our study, our objective was to quantitatively and qualitatively assess wall thinning and wall thickness channels in both infarct and non-infarct patients. So in a mixed cohort referred for scar-related endocardial ablation. And we were going to evaluate the co-localization between these CT characteristics, wall thinning and wall thickness channels, with ILAM-derived deceleration zones. So it was a retrospective cohort from a single institution here. They were all patients that underwent high-density substrate mapping using CARTO with a pre-procedural CTA with inHEART reconstructions that were merged using the CARTO merge feature, using fiducials that were derived from CARTO sound reconstructions. So these are ultrasound-based fiducials at the apex and the aortic root, coronary arteries in mitral annulus. And we quantified the area and localization of wall thickness less than 5 millimeters. We had blinded observers delineate putative wall thickness channels, and we then assessed the overlap between deceleration zones with these features. We had to exclude patients who had imaging quality that was not good enough for analysis, or who had their substrate maps lacked the density for analysis. So we ended up looking at 21 patients with infarct cardiomyopathy and 13 patients with non-infarct cardiomyopathy. We did manually adjudicated annotation for our points using the ILAM technique. Instead of using last deflection, we really wanted to get the last near field signal. So we used the last bipolar sharp signal that had a corresponding unipolar, or if there's no good unipolar, the last sharp signal above the noise threshold. These wall thinning heat maps, as I mentioned, show the degree of thinning from 1 to 5 millimeters, and you can identify these putative wall thickness channels by areas of relatively preserved thickness surrounded by thinner tissue on each end, and with a connection between normal tissue on each side. And so here's an example of a transverse and longitudinal channel in this wall thinning scar. These were co-registered, as I mentioned, with our ILAM maps, just to give you 3 different examples of what that looks like. And so you can see the decel zones circled on the left maps. The primary decel zones were the ones that were latest in the window or had the closest approximation with a clinical isthmus if it was identified during the case, or the best pace map. You can see the progression of co-localization over there as you superimpose the wall thinning map. You can project wall thinning channels, and then we look to see if there was overlap within 5 millimeters of thickness there, or 5 millimeters distance there. Our patients were a typical substrate-based or scar-related VT-based cohort, a mixture of infarct and non-infarct cardiomyopathy, a mixture of VT storm and non-VT storm cases, and a relatively small amount of very advanced heart failure, and a good mixture of first-time and repeat ablations. The amount of wall thinning in terms of surface area of wall thinning here by each threshold of 5 millimeters down to 1 millimeter was significantly greater in the infarct patients, which is not surprising. We know that that infarct can lead to more thinning than non-infarct cases. So that was borne out in our data here. The distribution of scar locations based on wall thinning was slightly variable between the 2 groups, but it's hard to in such a small cohort to really have any hard conclusions there. In terms of the number of wall thickness channels and their relative orientation relative to the scar, longitudinal, transverse, oblique, was overall relatively similar to the groups. Most of these channels were longitudinal and transverse, fewer of these curved or more distal channels. And the number of channels was not significantly different between the 2 groups. In terms of the real main figure of the paper is I show here, it shows that the overlap between wall thinning and these decel zones, again, are surrogate of a VT isthmus, and during substrate ablation using the strategy, there is a high sensitivity for the wall thinning areas all the way down to 2 millimeters co-localizing with the decel zones in the infarct patients. The non-infarct patients had less of a correlation, 20% for the whole cohort of non-infarct patients there. However, that was driven by the fact that there was so much less wall thinning in these patients, and about 2/3 of these patients had no wall thinning at all. So if you take a look at the patients in the non-infarct cohort that did have wall thinning present, there was a better correlation, but it still wasn't quite as good. It was about 50% instead of 95% sensitivity for identifying the functional substrate mapping surrogate, the D cell zones. Now, in terms of the wall thickness channels on the lower panel there was a moderate correlation, 50 to 60% or so in the infarct cohort in terms of these D cell zones being in one of these specific channels. However, it was not a perfect correlation, especially in the non-infarct correlation group. Now, putting this together, we can say that the infarct patients are more likely to have areas of wall thinning, and certainly a larger surface area of it. Wall thinning is more sensitive for localizing D cell zones in the infarct patients. However, if wall thinning was present in the non-infarct group, performed almost as well as the infarct group. A wall thickness cutoff even down to 3 or even 2 millimeters, which is a smaller surface area, still had a good correlation. And so what that does, what the clinical implication, in my opinion, is that allows you to prospectively know which area of the heart you can focus your high density substrate mapping in. It might even help you choose which wavefront of activation you're going to use. And so I think that's helpful prospective information, especially if you're going to be using more than one wavefront during a procedure. Wall thickness channels, they have moderate sensitivity, but relatively low positive predictive value. And so I don't think that wall thickness channels alone are enough of a surrogate to replace functional substrate mapping. For substrate ablation, that needs prospective work to bear that out. But of course, the limitation of this study being that these are surrogates for VT isthmuses in the critical parts of the VT circuits. And so how this translates to actual VT isthmuses that can be mapped was not assessed in this retrospective cohort. Another limitation is this was an endocardial only cohort. And as we all know, that non-infarct patients are more likely to have mid-myocardial epicardial substrate than the infarct patients alone. So that's a limitation there. And so I think that's a good point to guide future work, that we would love to collaborate with groups like Dr. Winterfield to see if some of these answers can be assessed in the future. So I'd like to thank our group here, my co-authors. I'd like to thank the Bordeaux group and inHEART Medical for helping support this investigation as well. Thank you very much.
Thank you, Dr. Maher. So panelists, we'll open it up to you. I know Dr. Sultan and Dr. Pavlović, we haven't heard from you yet. If you have a question to ask, feel free. Go ahead.
Yeah, Dr. Maher, very impressive work. Congratulations. I was just wondering, or maybe I've missed it. Did you also look at the scar extent? I mean, you've nicely shown that the thinning correlates nicely with the critical isthmuses or with the critical channels, but is there any correlation also for the extent of scar itself? I'm saying that if you have small scar areas, although there's a lot of thinning, that these might not produce that much of desolarization as opposed to bigger sites of scar. Did you look at that? Or maybe I missed it.
No, of course. Are you referring to the bipolar scar during mapping, or are there imaging characteristics of scar?
Both, the combination of bipolar mapping and also during, I mean, for the inHEART CT, if you look at the scar extent, is there a small area of scar extent with wall thinning? Is that the same as a bigger scar area with the same thinning?
So we did look at the bipolar scar. It wasn't, we didn't include it as part of this manuscript, but there was a good correlation. The bipolar scar was typically contained inside an area of wall thinning, and actually in our cohort, the area of wall thinning seemed to extend beyond the bipolar scar using the traditional cutoffs of 0.5 to 1.5. So it's a little, if you're using 5 millimeters of thinning as your cutoff, that was a bigger surface area than the endocardial scar. There's probably a better match for about 3 millimeters or so if you're looking for a tighter correlation. In terms of other CT features of scar, we did look at the inHEART segmentations of late iodine. We did run those sequences, but looking through those scans, I think the signal to noise ratio wasn't up to the point where I was comfortable making quantitative assessments, but they bring you to the same area as the wall thinning. There's a good agreement in area of the heart.
Excellent. Maybe a short second question. Is there, did you also, I mean, what happened to the sites where you could not detect any alarms or any deceleration zones, which were showing thinning, obviously? So we always struggle to either ablate them or not. Will this be channels in the future that we have to tackle, or can we leave them alone? I mean, there's the inHEART study going on, in your heart study going on, maybe shedding some light on this aspect, but maybe you can share your thoughts on that.
Yeah, so oftentimes these decel zones, they weren't far off from the wall thinning if there was wall thinning. Sometimes in these maps you can get the appearance of apical wall thinning, where when we do the endocardial mapping, we don't often see electrical scar in those areas, and so there's a little bit of a disagreement there. Typically, when there's apical wall thinning on the inHEART map, when we compare it to the actual EGM map, so I think that disagreement probably drove some of that data as well.
Agreed. Thank you.
Dr. Pavlović, go ahead.
No, Nikola? Okay. Great work. Thanks so much. I was just wondering about the non-ischemics. There it looks pretty futile to use the technique. Did you do any epicardial maps? Question number one. And how often, as compared to ischemics, did you actually find decel zones, regardless of the imaging part, just the functional part?
That's right. So most of the non-infarct patients were able to find at least one decel zone. Oftentimes, but endocardially, it was those kind of high basolateral type areas where activation is kind of ending anyways. And so whether those decel zones are good correlates for VT isthmuses, I think is a little more fraught. And only a small number of patients in this cohort at epicardial mapping, not enough to be able to derive any sort of conclusions in such a small cohort in the non-ischemic group. But I think that is driving the low performance in the non-infarct group for this strategy, is the fact that the critical areas of slowing are more likely to be mid-myocardial or epicardial. And so a future study would certainly need to look at this with both endocardial and epicardial mapping. And of course, many patients with non-infarct cardiomyopathy who have decel zones have no wall thinning at all. And that's the other side of the coin.
Yeah, would you put your buck on the CT late iodine then for looking for scar volume? What the MUSC group was presenting?
I think that would be a great idea. I am jealous of the quality of CTs and the technologies that groups like Bordeaux and MUSC have for that. And so if we could get our hands on a photon counting CT, we would love to look at that.
Go ahead, Dr. Pavlović.
Just a practical question. Do you always map, whether ELAM or map the VT? So do the bipolar, unipolar, it doesn't matter, use the multi-electrode mapping catheter, or do you ever proceed with the ablation, let's say, based on wall thinning and presumed VT channels?
That's right. We have not taken it to the inHEART style extent where we're using the CT wall thinning or other sorts of scar segmentations and just going right with our ablation catheter and taking care of channels or looking at signals there. In all of our patients, we're still starting with a high density substrate map in all of these cases. And so we've not yet gone to an image guided ablation. We use this as mapping augmentation technology. So that's certainly an exciting direction, however.
Great. Thank you, Dr. Maher.
Thank you.
Dr. Pavlović, I think this is a good time to transition over to your presentation. Again, attendees, if you have questions for any of our presenters or our panelists, please feel free to submit them in the Q&A at the bottom of your screen, and we'll try to work them into the conversation here.
Can you see my slides?
Yep.
Yeah.
I can. It looks great.
Okay, thank you. So thank you for the invitation and the opportunity to share the, I would say, small but growing clinical experience with image-guided structural VT ablation. my disclosures and just a little bit background. So I'm coming from Croatia. We are a relatively young EP center. 5 physicians, 4 ERA certified. Majority of the team moved from another hospital 2 years back and started, let's say, with the normal ablation program early 2022. We have currently 1 lab with around 50 structural VT ablations per year. I have to say 2 out of 4 of us were trained with one of the panelists. So whenever I'm doing something wrong, so I can, or you can take it up with Christian Sticherling. So when I was discussing with Dr. Darval almost year and a half ago, why would we need imaging for VT ablation? And I had to present that to my hospital management with all the reimbursement issues we have in our country. We've heard all about this before in the talks. So whether we can know the substrate before, plan the procedure itself, plan the access, can we be more efficient? So reduce procedure times, and of course, end of the day, reduce complications and improve outcomes of our patient. So currently, how we do VT ablations for a year now. So it's using inHEART, of course. We plan our approach based on the substrate. We, let's say, pre-deploy. So based on what we get, we plan the ablation points. After gaining access, regardless, epicardial, endocardial, we merge the maps minimally, pulmonary artery and coronary sinus. If we are going retrograde, we also map the aorta, or in a case like this, in a LVAD patient, the outflow cannula, integrate, and of course, we then ablate with solely ablation catheter use, so no mapping based on substrate we have. And of course, at the end of the procedure, we hope for non-inducibility. These are our data. Sorry, I can't see the slides. So last year, almost 50 or almost 40, structural VT ablations. 23 were guided with inHEART, 16 conventional. And this is, of course, non-randomized data, just clinical data. So if you see, we had 8 patients, or 50% of patients with VT storm, which were deemed by the operator or clinician not suitable for doing the CT, waiting for the reconstructions, usually end of the week or weekend, or part of those were at the beginning of our usage of inHEART, where we had organizational issues with the radiology. 5 of our patients had 1 or more ablations before and were referred to us once we started the VT ablations guided with the inHEART. So what we found in our patient cohort is that we had significantly shorter procedure times using the inHEART reconstructions, significantly lower usage of the fluoroscopy. And for a majority of our patients, we were able to end the procedure using only the ablation catheter. So in 2 out of 23, we had to, at the end of the procedure, due to still inducible VTs, change our strategy and do the complete substrate mapping. Of course, with conventional VT ablation, in almost all patients, we use the substrate mapping. It's actually 16 out of 16, but 1 was so unstable that we started with just the ablation catheter. Interesting thing is that after we deploy planned lesion set, the VT was still inducible in 23% of our patients. So we had to deviate from initial plan. But in, again, most of the patients, so 2 out of 23, we had to open the multi-electrode mapping catheter, do the whole substrate. But in 6 patients, we were able to complete the ablation just with either extending the lines, additional ablation lines, or mapping substrate near the exits with the ablation catheter. and we ended up with no inducible VTs at the end. We had one complication in our whole cohort, which was access site requiring surgery plus RBC transfusion. So I would say, based on really small and but growing experience, it seems feasible to use solely ablation catheter. It does seem to reduce procedure times. For us, due to reimbursement issues, it was important that it did save one mapping catheter. Of course, we are hoping and looking forward to see the data from the randomized control trial. One thing which is important, I was asked by several smaller centers whether they would be able to use inHEART for VT ablations just based on the reconstructions. So very small or no experience in VT ablation. Under no circumstances does this replace the knowledge and experience in VT ablation. And of course, once you're done, there's always time for rest. Just to translate this in Croatian, this is, take it easy and have some rest on a 50-year-old truck. Thank you.
Thank you, Dr. Pavlović. Great presentation. Panelists and presenters, questions for Dr. Pavlović?
Maybe I have one. That's great, Nikola. It replicates a bit our experience, but I have one question. Is how do you define your targets in non-ischemics? Because and it's also similar to the findings that Tim presented earlier. If you're based on wall thickness only, it doesn't work in non-ischemics. If it does, it's in a very small subgroup of old chronic myocarditis that, in fact, are transmural, so they may act as transmural infarct and infarct. But most of the time, you can't. So, and even if you have late iodine on these intramural scars to identify channels, it's extremely complicated. So you at least used pace mapping, right? Or was it only lines drawn before entering the lab?
So it was lines. So we had 8. I did not break down the data. So 2 patients where we used at the end of the procedure or after deploying the lines. I think we had 7 or 8. I can take a look. I think it was 8 non-ischemics. 2 were, so we had to map from scratch, everything from scratch. We were lucky that we had a couple of patients with small lateral scar, then based on late iodine scar, we played around with pace mapping, of course, entrainment mapping and everything. And we had 2 patients. One, unfortunately, we managed to do with septal scar. One was terminated with ablation, and the other patient, which I was discussing with Richard, we terminated with bipolar ablation in the septum, but recurred 6 months later and is now being planned for stereotactic radioablation. So it's extremely difficult, small number of patients. So far, we were, let's say, more or less lucky in majority of them.
Yeah, because usually what we advise to the centers that use the inHEART technology is, we do not yet advocate for going all in, as to, defining targets from imaging. We're waiting for the randomized control trial. But you have a very important message here, is that even if you are going directly for image-guided ablation, in our experience, it's in about 1/3. We'll see how the RCT says, what the RCT says, but you still have VTs that are inducible afters that you have to go for after. So you have to be trained, a very skillful DP. It shortens the procedure. If you have remaining VTs, you've treated most of the substrates, and we believe that we are more effective because we're treating also channels that may not be inducible at the time of the procedure by doing so. But we have to keep in mind that very often you need to convert to a real electrophysiologist,
Yeah, so it seems to work in couple of, so ARVC and ischemics, which we did with only ablation catheter, with non-ischemics, it gets a bit tough. It's a small cohort, 8 patients with non-ischemic. We were lucky that 2 had only septal scar. two with lateral. So, I mean, then you can play around. You can even isolate it, connect it to the mitral annulus, and the procedure we done inducibility. But end of the day, you need to know how to map the VTs. I mean, do the ablation.
Thanks.
Dr. Sultan, I believe you have a question.
Yeah, it has been answered in parts already, but the question is there a reason, aside from financial reasons, why not to use high-density mapping catheters, multipolar catheters in all those patients? Because for me, one of the bigger values is the combination of having both a nice high-density endocardial map or epicardial map using electroanatomical map in conjunction with inHEART, for example, with imaging, because sometimes we can then, you know, render sites more unexcitable. We get a better impression, which is really a target area. And also we had a few cases, to be honest, where the imaging did not capture all the substrate, and we were able to find more substrate with electroanatomical mapping, which was really helpful in some of those cases. So that would be, let's say, my question, or just my remarks on that.
I completely agree. So so one thing, it does shorten the procedure. So I like doing the substrate maps and everything. The first cases we did together with inHEART team, we did it this way. But then we said, okay, let's try at least first in ischemics, then all patients, let's try to use only the ablation catheter. I would say even it would go even in our healthcare system, but we have some problems with reimbursement. So if it can be done, at least I said we are working in one lab, it does shorten the procedure. That's for sure.
Great. We have a couple of questions that have come in from attendees. The first one is, how do you merge between CT and EAM maps? And are you confident of the merge to the nearest millimeter for VT possible channels?
That's a great question. So there are multiple strategies to merge. The one we chose, because we're over 90% transeptal only for our VT cases, we needed to we didn't use the aortic arch or the great vessels as a fiducial, which is commonly used. We used the Cardo sound module, which allows you to integrate ICE imaging to create a very accurate anatomy. And we take certain fiducial points on there that are easily identifiable and reproducible in both the CT and the ICE. So we'll use the coronary cusps and junctions of the cusps, the left main coronary artery, the mitral annulus, and the apex are the most common one we use. We in our series using surface comparison to estimate error during the merges after complete mapping. It was about 5 to 7 millimeters. And I think that's a really important point. Even with the best registrations we could do, there's still enough error that it's going to take you a few millimeters off your target at least half the time. So I don't think you can do millimeter to millimeter type registration and accuracy. Not to mention that these CTs are obtained on a different day, possibly a different part of the cardiac cycle, with different loading conditions, different ventilation, and maybe even different arm positions. And so I think it's, I don't think we're at the point where we can rely on 1 to 2 millimeter type registrations. And so I think that needs to be taken into account if you're going to be considering an imaging only based approach. So as a result, we flip that away, and we use inHEART to augment our mapping. And so what area of the heart is the area to focus on? Hopefully in the future, as things improve, we're able to get to that millimeter type resolution that's necessary for this type of work.
Thank you. We have one last question, and this one is for Nikola. What do you find in ICM mapped patients inducible after image guided ablation?
So in ischemic patients that we, after initial deployment, you mean probably after initial lesion deployment, we still had VTs inducible. It was either, so only a couple of cases in ischemic, we were off the target for a couple of millimeters, meaning missing the border zone or the exit. One was septal scar, anteroseptal scar, where we terminated the VT from the right side, and one was just not deploying the inferior scar connection to the mitral annulus. So, but those were only a couple of patients with ischemic. Most of the patients we had to map or do much more ablation was in non-ischemic patients.
All right. Well, thank you to our presenters and our guest panelists. It's been wonderful speaking with you all today and hearing the discussions. And thank you for your time, sharing again the inHEART solution and the recently presented data. To all of our attendees, we also thank you for joining us. If you certainly have additional questions, feel free to reach out to sales@inheartmedical.com. And to watch previous inHEART webinars, please visit inheartmedical.com and select webinars from the references main menu option at the top right of the screen. Well, thank you, everyone, and we hope you all have a great day.
Bye, everyone.
Thank
Bye.
you.